Okay, sorry for this. So basically, I'm going to talk about multimodality tracer functional imaging of dementia. These are my disclosures and outline of my talk. I'll start talking about background on radio tracers and multimodalities and how we can help in differential diagnosis of dementia and different subtypes of dementia, and hopefully help to solve diagnostic jigsaw puzzle of AD, frontotemporal lobe dementia, Lewy body dementia, and atypical Parkinsonian syndrome with cognitive impairment. So clearly nuclear medicine using the radio tracers, and radio tracer is the source of the signal, unlike in radiology where instrumentation inducing signal and changes and detects the effects. So nuclear medicine is actually application of tracer technology to medicine, and we have huge developments in the last 2-3 decades, and in both modalities and technology and tracer applications. So I just wanted to show this gross mismatch between CT and functional perfusion scan, which was introduced in 1990, and courtesy of my supervisor at that time, I mean, well, not that time, later on when I was doing my DAT scan in 97, 98 as one of the first team using in the world together with Amsterdam teams DAT scan in research. So this was they introduced a perfusion HMPO tracer, and then this is a patient with a brain death with a completely normal CT, and we opposite we have a normal volunteer with a perfusion, which is really depicted as a red or orange color scale in brain. So we actually know that brain structure does not equal function and vice versa, and functional imaging now is more and more utilized in clinical practice, but also in research. But we do have to understand that we need to assess both, and therefore multimodality imaging, combining function and anatomy, is actually changing management of patients. So when I'm talking about multimodality imaging, I will talk about nuclear medicine, multimodality imaging, PET-CT, PET-MRI, SPECT, and SPECT-CT. So we start imaging dementia with structural imaging with the brain MRI, or occasionally we could also do head CT head if there is some urgent or acute presentation to identify or exclude treatable causes such as hemorrhage or tumors. And in many cases, MRI is really helpful, but in cases when MRI is not helpful or it's equivocal, then we proceed using functional imaging. And in Sussex, we are fortunate to have a fantastic multidisciplinary team of neurologists and old age psychiatrists who actually pioneered use of functional molecular imaging in clinical practice together with my team in nuclear medicine. So basically, we moved then to FDG PET or other tracers that are available. So as I mentioned, perfusion tracer was discovered most, and then FDG PET started to be used in clinical practice approximately in 2000, depicting metabolism of brain. And then DAT scan, which was dopamine transporter imaging at the molecular level, at presynaptic level, and then technology developed with the multimodality PET-CT, PET-MRI, and also SPECT, because DAT scan is a gamma emitter labeled with 1, 2, 3, so we're using SPECT and SPECT-CT, which is single photon emission tomography, and more recently, utilization of amyloid plaque imaging in clinical practice. So it still takes a long time to diagnose dementia patients, and 40% of them are not diagnosed with AD during their life, and approximately 20% are actually found to have misdiagnosed on autopsy. So metabolism imaging is really important because it can actually depict changes even in some cases before really true clinical presentation, but we are not still screening patients, of course, yet. And we're also using imaging for early onset and early possible or probable AD, but not for definite clinical diagnosis. Why metabolism or perfusion imaging is important? Because it allows us identification of disease with specific metabolic brain patterns in neurodegenerative brain disease at early stage. And these are subtypes that we can image with the FDG PET. Clearly, I cannot go through all of them, but I'll try to illustrate some of them during this talk with some of our cases from clinical practice. And FDG is analog of glucose and allows measurement of glucose consumption. And as we all know, glucose is exclusive source of energy for the brain, and it reflects neuronal integrity of underlying brain pathology. So this is a normal FDG brain scan. As you can see, there is a high intense uptake in cortical gray matter and in subcortical basal ganglia and thalamus, while white matter is relatively photopenic. So recently we published PET-CT UK guidelines, which were actually led by myself as the chair of Intercollegiate Standing Committee of Nuclear Medicine at Royal College of Physicians, at Royal College of Radiologists, and that they both published, actually those guidelines are published at both colleges' websites and easily accessible. And there is a section on neurological indications, and one of them is definitely dementia. So we should be using FDG PET to assess progressive cognitive decline, where Alzheimer's disease or frontotemporal dementia are possible diagnoses if structural imaging has been inconclusive. We also use FDG PET as adjunct in differentiation of degenerative Parkinsonism, particularly if combined with DAT scan and with MIBG. So that's where multi-tracer imaging come to a really scenario when we need to differentiate subtypes of dementia if clinically indicated, clearly putting in the context of the clinical presentation. So characteristic perfusion metabolic patterns are similar with the metabolism and perfusion. They are actually matching. So frontotemporal lobe dementia would be depicted as hypometabolism in frontotemporal regions, Alzheimer's disease in temporoparietal region and posterior parietal cortex, and multi-infant dementia is multiple areas of the actually hypometabolism, but for vascular dementia, we are usually not doing functional imaging because MRI is a modality of choice for vascular dementia, unless there is a mixed pathology, when we can then include functional imaging as well. So we can also do statistical parametric mapping or different application of different quantification, because clearly using radio tracers, we can quantify our images. And clearly, this is a Z-score illustration in a purple blue color. So these are the areas that are hypometabolic, the areas with the reduced metabolism, and in Alzheimer's disease, as I already mentioned, it's a parieto-temporal region, precuneus and posterior cingulate gyrus. And in Lewy body dementia, we have a real overlap in FDG PET, but occipital region is also involved. In frontotemporal dementia, it's a frontal, anterior cingulate, and temporal regions and sensimotor areas. So firstly, when we report on scans, we look whether there is a predominantly posterior pathology, predominantly frontal, or predominantly unilateral. And clearly, that would be our first puzzle to look if it is posterior, predominantly hypermetabolism, it could be Alzheimer or Lewy body, predominantly frontal, frontotemporal, dementia or supranuclear palsy, and predominantly unilateral, for example, primary progressive aphasia or other differentials as on the slide listed. So I'm going to concentrate now on three main differential diagnoses. And as we said, with FDG, we can image selective neuronal loss, which is then illustrated as hypermetabolism in a hippocampus or temporoparietal neurocortex. But we also can image beta amyloid peptide accumulation with a beta amyloid plaque imaging, and the tau proteins with the tau imaging, which is currently only exclusively used in research. And therefore, I'm not going to talk about this area because that would be really far too much for 20 minutes. So if MRI is abnormal, we stop, as in this case, clear-cut abnormal hippocampal atrophy. But if MRI is normal or equivocal and diagnostic suspicion for Alzheimer is possible or probable, then we will proceed with FDG PET, where diagnostic accuracy was reported from 89 to 100%. Clearly, this is actually impossible because we can't have anything 100%, but that was when we had the first limited studies. But later on, all studies are around 89 and plus. So cerebral metabolic changes can be even detected before symptomatic manifestations, but combination with structural imaging is advantage. And FDG PET should be performed in two different categories: when mild and moderate dementia is on unclear etiology, and when progressive cognitive decline that all attempted treatments have failed to reverse. So in this first group, FDG PET will decrease false negatives and false positives. For example, false positive from 23 to 11%, or false negative 8.3 to 3.1%. While in second group, FDG PET will also decrease false negatives, but will increase true positives from 25.8 to 49%. So this is a PET MRI image illustrating really hypermetabolism in a cingulate region, posterior cingulate, and that's how it should be, and it's how it's really nicely depicted with the PET MRI. So once again, typical appearance of Alzheimer's disease on a PET, and our patient, Dr. Rajak's patient, of 54 years old male with cognitive impairment, and FDG PET clearly showed unequivocal abnormality. You can see that if you remember, it should be all symmetrical, even throughout the cortex. When we have a temporoparietal reduction, was very difficult diagnosis, and truly there was not true differential here. That's AD type pathology, but we have proceeded with amyloid scanning, and these dark gray images showing here all severe amyloid depositions in this young patient. So amyloid scanning, unfortunately not yet commissioned by NHS England, so we actually have some local funding for most difficult patients, for the youngest patients, and but not readily available. We can scan, we have a possibility, and we are doing research as well, studies with amyloid. So we are hoping that NHS England will commission amyloid. We published in our guidelines that it should be used, particularly in younger patients less than 65 years old, where knowledge of the presence or absence of amyloid is expected to increase diagnostic certainty and influence patient management. So presence of amyloid depositions is not diagnosis of Alzheimer's disease. So positive scan is not diagnostic for Alzheimer's disease, but increasing likelihood for Alzheimer's disease. We can have a positive scan in Lewy body dementia, mild cognitive impairment, and some individuals with normal cognitive functions might have a depositions, but particularly in elderly age, above 70 or above 65. Therefore, amyloid scanning, probably in clinical practice, would be the most useful in the younger patients. Because we would not expect to have any amyloid depositions. But we can differentiate using amyloid scanning from other pathologies, such as, for example, FTLD, which is negative on amyloid scan. So this is a normal amyloid scan, and you can see how nicely we can illustrate white-gray matter differentiation. And we also have all quantification here normal, and negative beta amyloid scan is really having high negative predictive value. So virtually we can exclude amyloid pathology and Alzheimer's disease if the scan is negative. So interestingly, so far in research, 1 of 4 patients were negative, even there was a suspicious mild AD. This is a multi-tracer imaging in clinical practice, patient with HIV and a suspicious AD. And this patient was included in a research trial, and basically had amyloid scan, which was negative, excluding AD. As you could see, MRI was almost normal, just general volume depletion, so virtually reported normal. And patient developed Parkinsonism and some Parkinsonian symptoms, and we performed the DAT scan, which showed definitely abnormal DAT scan. And then follow-up MRI in 1 year showed the mid-brain volume depletion typical of progressive supranuclear palsy, Hummingbird sign. So we could actually diagnose this patient with a PSP using a multimodality imaging. And clearly that scan showing much more abnormality than MRI, which was only showed abnormality and follow-up. So diagnostic puzzle for using multi-tracer imaging for patients suspicious having Alzheimer's disease would probably be different if we do have amyloid imaging available. And if the patients are younger than 65 or 70, we would suggest to start with amyloid imaging after a normal or equivocal MRI. Clearly, if amyloid is positive, we could stop there. If amyloid is negative, we can then combine with FDG to further differentiate. But for patients above 70, we can actually safely start with FDG because we might expect some amyloid deposition. And basically, clearly, we still can have a negative amyloid in this category as well. For Lewy body dementia, we should really start with the DAT scan rather than with any of those two. And we can actually differentiate subtypes of FTLD, not always, of course, but we really change the management using a multi-tracer or using a tracer imaging. And in frontotemporal lobe dementia, this is a typical Pick's disease, which already had a clear abnormality in frontal lobes and anatomical imaging as well. But a frontotemporal hypermetabolism is a hallmark of frontotemporal lobe dementia, but temporoparietal lobes can be also involved. So these are just some cases. Actually, our cases, this was a Professor Chan's case that we published a long time ago now, but ever since we have many cases like this, normal MRI and suspicious for neurodegenerative disorder with a clearly abnormal FDG PET with predominantly left side, anterior temporal, frontal, and anterior cingulate hypermetabolism, which was consistent with the semantic variant of frontotemporal dementia. Another case, again, from Sussex, right temporal variant of frontotemporal lobe dementia, which basically is a mirrored image of a semantic variant. So basically with FTLD, FDG is a starting point, and we can use FDG to differentiate subtypes, but also in between Alzheimer's disease and frontotemporal lobe dementia. Huge area of imaging is a very important area is Lewy body dementia, and Parkinsonian imaging is really a big subject, which I'm going to try to really cut in a way, because we have a DAT scan, which is in clinical practice. We have a MIBG. We can combine those two in order to differentiate between atypical Parkinsonism. We have all this imaging here, which is a dopaminergic PET, tau imaging, neuroinflammation, which are actually in research. And we are actually now in all possible guidelines, NICE guidelines, and also fourth consensus of the DLB consortium as indicative biomarkers. This is a typical balance loss for Lewy body dementia, and also absent uptake with the MIBG on the scan. PET and SPECT are only supportive biomarkers because they can be overlapping with the diagnosis of Alzheimer's disease, also posterior cortical atrophy. I just want to mention this study because that was a pivotal study for nuclear medicine. That was the first study published in 2007 for Susan Walker, when was the first time that we had a nuclear medicine functional imaging correlated with post-mortem analysis. And that when it was a game changer. And that's when we got accepted by clinicians believing in our scanning. So clearly, that scan can differentiate between Lewy body and Alzheimer's disease, should be normal in Alzheimer's, abnormal in Lewy body, and more updated study with the more patients shows actually specificity of 90% and sensitivity of 78%. And what do we see? We actually look for dysfunction at presynaptic level. We are using the DAT scan, which is eye of fluid pain, or FPCIT, which is analog of cocaine, which actually is labeled with the 1,2,3 iodine. And therefore, we can depict availability of dopamine transport at presynaptic level. So these are like, this is our first case in Sussex that we published with Dr. Tabet, and we were included in phase 3 and 4 trials for Lewy body dementia. So multi-tracer, dual tracer imaging is with MIBG to differentiate between atypical non-Lewy body Parkinsonism, where we would have a normal heart uptake, as in this case, but in a typical Lewy body Parkinsonism, uptake would be abnormal. People are advocating maybe using the MIBG first, but because it might predate that scan abnormalities, but the problem with MIG might be that we have interference with many drugs and also with some pathology. So basically, I leave MIBG for atypical Parkinsonism, particularly differentiation between MSA and Lewy body type pathology. And another area which we can combine is that scan with the FDG. And this is a final case, which is very interesting because there was a normal MRI reported. On review, there was some change in vascular changes in parietal region. And that scan was abnormal, suspicious for Parkinsonian syndrome. So that scan was just originally reported normal, but then on review, we could see that there is a weak coma, and we suggested the FDG PET. And FDG PET was really heavily abnormal, as you can see, frontoparietal low hypometabolism with reduction of the uptake in basal ganglia on the right, typical of corticobasal degeneration. Just to summarize, we have 3 main brain tracer and 1 extra brain tracer that are used in the nuclear medicine and to help early diagnosis of dementia. One is FDG. We have amyloid imaging with a high negative predictive value, and the clearly future of amyloid imaging, potentially selection of patients for anti-amyloid drugs, and before modifying treatments and monitoring response to treatment. And then finally, that scan, which can be used as in the context of multimodality imaging, has the potential to differentiate not just between PD, Lewy body dementia and Alzheimer's disease, then also atypical Parkinsonian syndrome. And we do improve timely diagnosis. We are likely cost effective. We have some cost effectiveness studies that I haven't shown, but I think for NHS England, they were asking for more cost effectiveness studies for amyloid imaging. But now with the new modifying treatments, I think they finally realized they need to do scoping exercise, which they are doing, which is great news. And these are just images of our tracers that are in research, tau and inflammatory tracer, which is the TSPO. I would like to thank you to organizer and to my colleagues and the group from Sussex for like really fantastic collaboration during the years, and to my team from Brighton.